Hello, my name is Rustam Al-Shahi Salman and I'm a neurologist in Edinburgh and the clinical director of the Edinburgh Clinical Trials Unit. Thank you very much indeed to the organisers for giving me the opportunity to talk to you about a strategy for reducing the carbon footprint of clinical trials at the 7th Trials Methodology Symposium. So first of all, my disclosures. Well, for a start, my research focuses on stroke and in particular bleeding within the brain hemorrhage. And that's a disease, a non-communicable disease that's driven by many of the carbon intensive aspects of our lifestyles. It's a disease with a devastating outcome. And that's why I'm committed to investigating treatments to improve its outcome in the perfect research design of randomized controlled trials. I'm also concerned about methodological rigor, doing trials well, and avoiding doing trials that are unnecessary. In my personal life, one of my hobbies is being a road cyclist, and all of these things really converge to make me care about the carbon footprint of clinical trials and ways to reduce it. I'm also the president of the British Association of Stroke Physicians, and that was the first professional association to join the UK Health Alliance on climate change. And by doing that, I came into contact with several other people who have done the lion's share of the work behind one of the initiatives that I'm going to tell you about today. So we're all understandably really preoccupied by the COVID-19 pandemic at the moment, attending to infection control and believing that if we do that, we'll somehow recover and all will be well with the world. But we already knew before the pandemic distracted us that a recession might be coming, and that will only be worsened by COVID-19, and the looming threat of climate change has been there for many decades, known to us all, really, although some deny it. This was a landmark editorial recently published simultaneously in more than 230 medical journals, which is an absolutely unprecedented step for any single article. And medical journal editors published this editorial calling for emergency action to limit global warming. And their two basic points were: global targets are not enough. We're still trying to persuade countries around the world to set them and adhere to them. And really, cooperation hinges on wealthy nations doing more. So we hope that COP26 in Glasgow will provide an opportunity for the wealthiest nations in the world responsible for some of the greatest carbon consumption to do something about this, a climate crisis that disproportionately affects the poorest countries with the worst health status in the world. The Intergovernmental Panel on Climate Change set this target of limiting global temperature rises to less than 1.5 degrees centigrade. And of course, we're used to hearing about this and to see mass action from lots of organizations that know full well what the impact of the climate crisis will be, including the Healthy Recovery Group last year of more than 350 organizations representing more than 40 million healthcare professionals from 90 different countries, calling on G20 leaders for a healthy recovery. So here's to next month in Glasgow. So why should we be concerned to do something about climate change? Well, on the left, you see an x-axis of hundreds of thousands of years back from the present, showing you the cycles of carbon dioxide concentration in the atmosphere that have happened over the years, including the ice ages. But as you can see, we're going through nothing like an ice age at the moment. Very recently, global temperatures and carbon dioxide concentrations have escalated rapidly. And you see in the shaded panel the rapid escalation that's happened since the world industrialized in the 19th and 20th centuries. with an increasingly precipitous climb recently. On the right-hand side, you see the global temperature rise in comparison to the average temperature between 1961 and 1990. And here you see why we should be worried that we may not limit temperature rises below 1.5 degrees centigrade in comparison to the era before mass industrialization of the world. The temperature rise is just keeping on going, no matter which monitoring system you use to measure it. So we've all been quite optimistic because the pandemic has kept us all at home, made us more interested in active travel, less inclined or able to fly by plane and other modes of transport. And there was seemingly a 7% drop in global fossil fuel emissions measured in billions of tons of carbon dioxide since the pandemic kicked in. But of course, all of this is on the background I showed you on the previous slide of rising carbon dioxide emissions, and also our knowledge that at times of previous global catastrophes, like the Spanish influenza pandemic or the Great Depression or the end of the Second World War, the oil shocks in the 70s and 80s, and the financial crisis in 2008, at all of those times, there's been a characteristic drop in carbon dioxide emissions in the world at that time, followed soon after by an increase and a steady rise over the years. So I don't think we can be too complacent because of the impact of the pandemic. So why should we as clinical trialists care? Well, climate change itself leads to all sorts of health hazards. Extreme weather events have a variety of different effects. Heat stress obviously causes a large amount of heat-related illness, and this is rising in the elderly in high-income and other countries. Air quality clearly worsens respiratory and cardiovascular diseases, and poor water quality worsens infections and their spread. Poor food supply leads to undernutrition, infections, and changes in insect distribution, vectors of disease around the world as a result of temperature rises also spread all manner of infectious diseases. And finally, there are huge consequences on the physical and mental health of populations from climate change as conflict increasingly arises from the direct and the indirect effects of climate change. This is a systematic review of the association between different types of climate change and health risks. And you see the different health risks as columns here, and the different types of climate change or consequences of climate change in different colours. So you see there's good evidence that meteorological and extreme weather events lead to infectious diseases in association with those changes. They also increase the risk of death, and you can see that those two aspects and air quality, poor air quality, are associated with respiratory, cardiovascular, and neurological diseases, and so on across a range of different health outcomes. So our greatest concerns here are with, and should be where the evidence is best, about the risks of infectious diseases, death, and respiratory and cardiovascular and neurological consequences of a variety of consequences of climate change. It's not all doom and gloom though. The Lancet 2020 countdown on health and climate change did show us that some change has at least been happening in healthcare systems. On the left-hand side, you see that over time recently, there's been increasing spend on adaptation of healthcare systems to climate change to try and mitigate some of its effects. Also, you see on the right-hand side, the commitment of different institutions globally in red to divesting from fossil fuels, not investing in fossil fuels. And in blue, you see how healthcare institutions have responded to that. But after many of the very largest ones committed, you see that that has plateaued. Yet there are many more institutions that could be doing this. So some progress, but clearly in line with rising CO2 emissions and temperature rise in the world, there's no room for complacency and we need to do more. In NHS England, for example, data collection about these contributors to greenhouse gas emissions has been pretty good. And it's given us a good picture of what has changed over time. And in particular, for example, you see the reduction in the red bars at the bottom, perhaps the greatest reduction, where the use of anesthetic gases has been addressed to minimize emissions from those. But there remain many aspects of the supply chain that are the largest contributor to carbon and other gas emissions of the healthcare system, and these need to continue to be addressed. Accurate measurement of greenhouse gas emissions in the National Health Service has given us a really good picture of what the largest contributors to it are. And you see in 2019, the supply chain was by far the largest single contributor to greenhouse gas emissions. Pharmaceuticals and chemicals, medical equipment accounting for the majority of that. Delivery of care and the way our buildings run, the way we manage water and waste, anesthetic gases and travel are the second largest category of contributor. And then thirdly, we as staff members also need to think about how we travel and how visitors and patients travel. So that gives you a good idea of the top 3 contributors to healthcare greenhouse gas emissions. And as a consequence of measuring this accurately, understanding it and recognizing that more can be done, to its great credit, the NHS is the world's first national health system to commit to net zero. And you may want to review some of the For a Greener NHS pages on the web. So the question for us in clinical trials is, could clinical trials units do the same? Well, back in 2007, the Sustainable Trials Study Group, led by Ian Roberts at the London School of Hygiene and Tropical Medicine, proposed how clinical trials could be decarbonised and made more efficient. In this paper in the BMJ, they used data from the CRASH trial of steroids for head injury done worldwide to estimate both the direct and indirect emissions of that trial. These data were collected retrospectively, and the authors argued that they were not a complete quantification of all the emissions, but you can see that the majority, the largest single category of their carbon dioxide emissions were from the trial coordinating centre's premises. Distribution and delivery of drug supplies in this global drug trial was also a large contributor, and so was travel related to the trial, whether it's patients, investigators, or supplies. So they estimated in 1 year that 126 tons of carbon dioxide were expended. That's the equivalent of 525 return flights to New York City from London, with a fair amount of kilograms of carbon dioxide per participant, and even more per primary outcome. So they proposed ways of reducing our clinical trials footprints, focusing on use of renewable energy resources in our institutions, and using energy more efficiently. Simple things like voltage optimizing the power supply, dimmable lighting, adapting to ambient light conditions, automatic switch off of lights in rooms, and so on. All the things we know to be relatively easy to achieve. Also, travel could be reduced by massively reducing the bureaucracy in trials, which is wasteful in many ways, simplifying trial designs, for example, remote site initiation visits, and relying on effective networks of collaborators, and using video conferencing. So this was all proposed back in 2007, things that are much more familiar to us now, but why has it taken us 14 years to embrace these things to an extent, but nowhere near as wholeheartedly as we should have done, given what's happened to the climate between 2007 and now? So it's all of our responsibilities to raise awareness about these issues and do something about them. A couple of years later, there was a review of 12 NIHR NET-CC randomized control trials with a total of 4,800 patients. A retrospective analysis tried to quantify the average carbon dioxide emissions of these trials. On average, they were about 78 tons per year. And that's the equivalent to the annual emissions of 9 people in the United Kingdom. Travel generated the most emissions, and you see here the different categories of travel, with trial team commuting seemingly the largest, as well as study centres fuel use, participant-related travel, trial team travel, and transport of trial technologies around the UK being the leading categories. This is undoubtedly an underestimate, as the authors admit, and I think they weren't able to accurately quantify institutions' energy expenditure, which in the crash trial had been the largest category, as you saw. And then in 2011, the crash team showed that improvement in reducing carbon emissions was possible, and they implemented the findings from crash 1 in crash 2. And you can see here that in at least trial drug delivery, coordinating centre energy use, and trial-related travel, there were reductions between the crash 1 and the crash 2 trial. However, after 2011, things have really gone a bit quiet in this space until 8 years later, in 2019, the NIHR published its carbon reduction guidelines. And I would, if you haven't already read these, I'd urge you to do so and consider how you can implement all of them in your trials. They're very sensible, and most of them are not that difficult. The 19 recommendations were made concerning setting the research question and making full use of the existing evidence. In other words, don't do research that's unnecessary. Designing a trial efficiently, setting it up and conducting it efficiently, using remote and data efficient methods wherever possible. Avoid unnecessary data collection. We've often over-fetishized data collection in clinical trials, and monitor clinical trials sensibly. That, of course, is a message for sponsors of trials. Report research well, and reduce the environmental impact of the NHS through research designed to minimize resource use and carbon consumption in practice. So I'd urge you to refer to those guidelines, which may improve your practices even without further evidence. So in 2021, a group of us published this short commentary in The Lancet, really to look to where we should go next with the small amount of progress that has been made by a few key players in carbon reduction in clinical trials since the Sustainable Clinical Trials Group's report in 2007. So over and above the NIHR carbon reduction guidelines, we think that not only do researchers have a role to play here, but so too do sponsors, scrutinising their processes, their SOPs, and asking whether carbon intensive governance and monitoring methods are really essential, and whether they could be done more efficiently and with less carbon use. Funding bodies could certainly incentivise the measurement of carbon consumption by trials, the reduction of carbon in the conduct of the trial, and also the quantification of the carbon impact of the intervention in question. Research regulators could certainly encourage the quantification of carbon and its consideration in trial design, and publishers too could ask researchers to quantify the carbon costs and impact of their trials. We need incentives if we want people to do trials in a more efficient, lower carbon way. And we could also look at how much value there is of a trial's result in relation to its carbon impact. You could compare the health benefit to the carbon costs of an intervention, as we do with the financial costs of the trial and the intervention. But what has complicated a lot of this, as you have seen from the different ways we've quantified carbon consumption in trials in the past, is that we need a tool to accurately measure trials' carbon footprints. So with funding from the NIHR, supporting efficient and innovative delivery of research programme, a group of us obtained funding to enable lower carbon clinical trials by developing and testing a tool to quantify the carbon footprint of clinical trials and thereby inform the design of future trials that could be lower carbon. This has been led by the Institute of Cancer Research and the Liverpool Clinical Trials Centre, with 4 other trials units on board, and in partnership with the TMRP, the Sustainable Healthcare Coalition, Wellcome Trust, UK HAC, and ERM, who are specialists in measuring environmental impact. We've got 3 main aims. Firstly, to develop a process map to capture the entire carbon footprint of a clinical trial, both direct and indirect, and all the costs from the supply chain to our buildings to the actual conduct of the trial itself. We need to test the process map with selected clinical trials at the 6 participating trials units and identify particular carbon hotspots that could be addressed. And all of this would be groundwork for an online carbon calculator that you could use in your clinical trials to measure and monitor their impact. So what could you do at this stage about carbon consumption in your trials? Well, firstly, you could follow the 19 recommendations of the NIHR guidelines. They contain many sensible recommendations, including what we already know to be important, which is good patient-public involvement and systematic reviews of the evidence available so that we avoid unnecessary clinical trials. You should work with your own institutions to lobby for more efficient use of resources and carbon reduction in the way energy is supplied in your institutions and the way your buildings operate. Minimize travel in your clinical trials, whether it's shipping drug in inefficient ways, whether it's visiting sites in person for site initiation visits when remote site initiation visits would do absolutely fine, or whether it's patients and their carers traveling unnecessarily when remote or data-driven methods of follow-up would be adequate. You need to work on the supply chains of the materials that you use in your trials, whether it's the health technologies that are being tested or other things that you use for your trials. Demand your suppliers to show that they are decarbonising. Otherwise, if they don't, use an alternative supplier who does. Please help with the development and testing and use of a carbon calculator for clinical trials. Or even just do your very best while we're still developing that and publish your results. You can see from the evidence I've already presented to you how little has already been done in this area. And then when we've got a method of measuring carbon, wouldn't it be great to do SWOTs, studies within a trial, of interventions to reduce carbon consumption, to generate evidence experimentally that initiatives can reduce carbon consumption in trials. And then I think we all should just raise awareness of the importance of this issue, as well as acting to do something about it. And of course, we're all citizens of the world in which we are living through a climate crisis that is a health crisis because of the effects of climate change on human health. It's an opportunity for us to improve global health and recognise that the least well-served communities are the ones on whom the climate crisis has the greatest health impact. We have to try to keep temperature increases below 1.5 degrees centigrade and reach net zero by 2040. And we can all do that, but it requires a radical change in the way we live our lives and conduct our work. We did drop emissions by 7% during the pandemic, and we need to continue to do that. But until now, emissions have been increasing by 7% per year, not decreasing. So we really need to retain some of the more environmentally friendly ways that we've been living during the pandemic. So what could you personally do today, recognizing that changing your clinical trials may take a little bit longer? Well, if we read from right to left, the things one could do to save carbon dioxide emissions per year on the y-axis, well, the easiest thing for us to do is to change our light bulbs at home to more energy efficient light bulbs, and not use tumble dryers, and just hang our clothes out to dry, make sure we recycle, wash our clothes at cooler temperatures, and drive a hybrid car rather than a petrol or diesel fueled car. These are all things that I do in my home, but it's rather galling for me to see that they contribute actually very little to reducing my own carbon emissions each year. What I'm going to need to stop doing is eating meat and switch to a plant-based diet, get an electric car rather than a hybrid, buy green energy, which I do, and stop flying, which I haven't done for a long time. Ideally, one would live car-free, and I do cycle everywhere I can. And of course, for those of us who have reproductive decisions ahead of us, have fewer children, because humans are the greatest impact on the environment. So this graph, I think, puts in context the individual actions that we can take. So I hope that I've inspired you to remain concerned about the climate crisis and shown you a few simple things that we can all do in our personal lives and our professional lives to minimize the ongoing climate crisis and preserve our world for our children and future generations, whilst conducting lower carbon clinical trials to improve their long-term health. Thank you.